amene sokhala mugayi ndi mugayi nazo na critical omina alida
Thank you so much to Amanda Glassman for hosting the first debate that we had. We are shortly ready to proceed with the second debate. We have talked now about the vaccine nationalization and global distribution. Some very clear thoughts here, both from politicians and the research community. And we are now ready to host the second panel, which is on global health. Amanda, you are with us. I would like to hand the floor again over to you, Amanda, if everything is ready on your behalf. Excellent. Yes. Thank you so much. The floor is yours to you and your panelists, Amanda.
Okay, thanks very much. So we'll now talk a little bit about a secondary crisis that's occurring in the health sector in response to the COVID-19 crisis, the impact that all that is going on is having on the provision and use of essential health services. We're honored to be joined by the Honorable Helen Clark of the Partnership for Maternal, Newborn, and Child Health, Dr. Ole Norheim from the University of Bergen, Dr. Leslie London from the University of Cape Town, and Dr. Joy Mafi from the African Leaders Malaria Alliance. So welcome all. I'm going to quickly show a couple slides as a scene setter. Let's see, I will share content. So I'm just going to show you a couple of illustrative issues that are going on right now. So this is just something from a World Health Organization report on guidance to countries on what to do about interruptions in essential health services. But it's showing the utilization, the number of outpatient visits are there on the left-hand side. And we can see with the yellow line, that's what we expect people to use if what last year's data was predictive. And what we see is that since about March, there's been a drop in the use of outpatient services in Kenya that has persisted into mid-year. If we look at a case from South Africa, this is from a group of researchers at the Harvard School of Public Health and their collaborators. This looks at KwaZulu-Natal, South Africa. With the dotted blue line, it shows us when the first COVID-19 case was reported in March 15th. And again, the lighter line is what we saw in inpatient admissions or diabetes visits in 2019. And the solid lines are showing, again, a drop and sustained drop in the use of hospital services in 2020. They saw some resumption in some services and not others, but they also saw institutional mortality increase, particularly maternal deaths. Now, we don't know, obviously, if excess deaths that are observed in a country are undiagnosed COVID-19, but they can also be because of lack of attention from other kinds of services. And then finally, a quick look at, this is really interesting real-time data from Sindh province in Pakistan. Really wonderful vaccination data. I wish we had this for every country. On the left-hand side, those bars are showing us the number of children that are immunized and a timeline of when various measures were enacted, including, at the beginning, the first cases, the public spaces closed or flight bans enforced. But at the end, we can see vaccination rates go up as outreach activities resumed for the vaccination program, showing that it really is possible to get immunization levels up. Overall, still there was a fall in immunization, but I think it shows, even though there was this hit because of the lockdown and related activities, they were able to get back to business. So with that as background, I'd like to turn back to our panelists. I will stop sharing my screen and start with Helen. Could you tell us a little bit about what should we do to ensure that we don't fall back on progress have we seen, or that this fallback in progress is persistent? And how can we sort of sustain the fight against COVID while maintaining essential services? Thanks. I think you're on mute.
Right, off mute.
Great.
The saying of 2020, please turn off on mute. Look, from the Partnership for Maternal, Newborn and Child Health perspective, we do see that there has been a significant impact on health and well-being of women, children and adolescents from COVID. And some of that is long-lasting. And let's talk about why that is so. In the case of sexual and reproductive health and rights, for example, nearly a third of countries across the 105 surveyed by WHO had a third of services were disrupted across the 105 countries. And that's, that's quite dramatic. It means you don't have the skilled assistance at birth, you don't have the pre and postnatal care you need, family planning interrupted, more unsafe abortions, women's and babies to be born lives put at risk. And then we've seen, the reporting out of, for example, Nepal, published in The Lancet, which suggests that there were significant increases in stillbirths, which were occurring within health facilities in that lockdown period, and the neonatal death rates in the health facilities were up substantially as well. And then there's the lasting impact where children may have missed out on the vaccinations. Back mid last year, WHO and UNICEF put out preliminary data that suggested that for the first time in 28 years, there had been a reduction in the numbers of children completing 3 doses of the vaccine against the diphtheria, tetanus, and whooping cough. Now, that's quite serious if that hasn't been caught up with. I think, the sort of overarching concern is that the socioeconomic impact of the crisis has led to this very sharp rise in the number of people living in extreme poverty and hunger. And that always impacts back on health and well-being. 71 million people now estimated by the UN to have been pushed back into extreme poverty last year. And that number will be unlikely to revert to pre-pandemic levels on current trends for a decade. So, we can go on this figure after figure after figure and, how to overcome this and get the priority back on the basics so that we don't see more people consigned to miss out on a long-term basis. So to cut to the chase, mid last year, PMNCH issued a call to action, a call to leaders to protect and prioritise health and rights of women, children and adolescents during the pandemic response and recovery phase. We said we need strengthened political commitment. These services aren't optional extras, they're absolutely vital, and we need the policies and financing to back that. We need universal health coverage, we need social protection, basic social protection, which is universal. And a number of countries, including Norway, responded, very fulsomely. There were commitments made totaling more than $20 billion already. 3/4 of that funding for new commitments to address the COVID-19 response and recovery, and $3 billion to protect existing budgets in the women, children, adolescent health area. So, it's about leadership, it's about funding, it's about commitment, it's about placing, for us, women, children, and adolescents at the centre of what we do. And let me end on the note that, Norad is just such an important voice in this. You are a leader in the global health community, and I think you're very important in ensuring that when we say we're not going to leave anyone behind, we're not leaving behind women, children, and adolescents because of the way the pandemic has played out and created this secondary crisis.
Thank you. So let's now turn to Ole. In the previous panel, we talked about how to set priorities for the distribution of COVID-19 vaccine. And now we're really facing another kind of priority setting question. And I'll pose it to you at the country level and at the international level. So at the country level, budgets are shrinking, or revenues are shrinking. There's some capacity with international support for countries to expand to sustain spending, but we are seeing a contraction. How should countries think about prioritizing these essential services during a fiscal crunch? And then at the international level, some countries are cutting aid during a time when actually needs are increasing. And what would, on the other hand, also even in the World Bank surge, we're also seeing some reprogramming of loans that may have been destined for reproductive, maternal, newborn, child health to address, understandably, COVID-19 interventions, which may be good because it allows for the safe delivery of those interventions, or could be difficult because it takes money and effort away from those interventions. So can you reflect on those two levels of priority setting?
Thank you, Amanda. Yes, I want to echo what Helen said about going back to basics and setting priorities. And I think with what we have seen so far, the need to set priorities has become even more important. Early on in the pandemic, the WHO issued guidance to countries to protect essential services. But they didn't really say what services are essential. And our center, Bergen Center for Ethics and Priority Setting, has supported Ethiopia, among other countries, to define a basic benefit package using criteria like cost effectiveness, priority to the worst off, and financial risk protection. And what Ethiopia did during and early on in the pandemic was that they used this basic package under the umbrella concept of universal health coverage to define the essential services to be protected during the pandemic. And I think this is exactly the right approach, to go back to basics, provide basic healthcare, primary care, and services that provide most value for money. On the second question, countries cutting back aid, very, very problematic, of course, for many countries, because we see this double burden now on all the gains we had on the SDGs getting lost, and then the pandemic on top of this. So there are strong arguments and strong reasons to continue to support, both with decision support, but also now in the pandemic, especially supporting countries with vaccines as quickly as possible, as we discussed in the earlier panel. Thanks.
Thank you, Lily. Let's turn to Dr. London now. You're at the University of Cape Town. We looked at some of the data from KwaZulu-Natal. Can you reflect a little bit on what this crisis looks like where you're working, and what to do about it? What decisions need to be made?
Sure. So thanks very much for this opportunity. And I won't repeat what's been said already about what we know, that there have been massive cutbacks in primary care services across the globe, but particularly in low middle income countries. And the interesting thing is that while some of this was planned de-escalation, we called it de-escalation, much of it was actually forced on poorly maintained and poorly prepared health systems. And much of the de-escalation disproportionately affected the most vulnerable in society. So, for example, health services in South Africa during the epidemic actually suspended the provision of medical assessments for persons applying for disability grants. So even in a country that was wealthy enough to provide some measure of social security for the most vulnerable, we actually withdrew that during the time when they were even more in need. So it's not surprising the recent Oxfam report frames COVID-19 as the inequality virus, because its impact of the virus and the impact of states' responses is illustrative of the exacerbation of the chronic neglect of public health systems in a context of weak social protection, precarious livelihoods, and a failure to provide for the social determinants of health. So it is true that catch-up can do something about this, and we hear a lot about that. But and the Pakistan example was very clear. But I think such notions also imply that the health systems have the capacity to catch up, to respond, to show resilience, to rebound. And to the extent that they do, this is really a reflection of the incredible commitment and devotion of health workers and managers to save lives and promote health. But health system underfunding did not occur by accident, and in general did not occur through willful neglect by maligned leaders. It's a product of a system in which inequality is linked both to national and international conditions, and most recently evident in the way the world has divided itself up over intellectual protections for COVID-19 vaccines, which was not really discussed in the earlier panel around the question of a waiver. It's also the product of a system which, despite the best evidence, has seen international aid foisting market-oriented reforms onto health systems in developing countries, often to their general detriment. So what can be done? For this, I would draw on a call that was published in the BMJ Global in September by authors from across the globe, which draws on collective experience and evidence on the ground of successful responses. And it's a call that's made on governments and multilateral institutions to firstly co-develop through participative methods, comprehensive public health interventions based on collaboration, partnership, shared responsibility, dialogue, and solidarity at all levels within and across countries. Secondly, to recognize the agency and critical contributions made by communities in co-designing, co-implementing, and monitoring context-appropriate pandemic responses. Thirdly, giving voice to communities mobilizes resources, networks, and capital that health services do not have, but they need. For example, community health workers tasked with following up contacts of COVID-19 patients can simultaneously extend health promotion for NCDs into high-risk households. Health committees, which is an area I work in, who represent community participation structures, can disseminate COVID-19 information, develop novel local responses, build local support, and rebuild trust in a health system that's often experienced as aloof and hostile. Fourthly, the call to promote, invest in strengthening capacities for local production, and I include in that questions of vaccines and citizen-led technology and system innovations for health. Fifthly, to implement and monitor multi-sectoral actions to address the socioeconomic and environmental determinants of risk and vulnerability. And lastly, obviously, ensuring increased, sustained, and equitable funding for comprehensive public health care. So with regard to that last call, I think it's quite sobering to note that in the COVID-19 accelerator, of the four domains, the health system connector pillar is really important, but hasn't been funded in the way that the vaccine pillar has been funded. If we don't have functioning health systems, as DG Tedros said, no amount of health technology will prevent future waves, illness, and deaths. And I think for low middle income countries, this is the real challenge. If the highest attainable standard of physical mental health as promised under the Convention on Social and Economic Rights becomes a reality, not just for residents in northern countries, but also for everyone, rich and poor, north and south, urban and rural. Thank you.
Okay, thanks very much. I think you're, in addition to the other points that you've made, drawing attention to the social determinants of health is extraordinarily important, and that the priority setting process to sustain outcomes in other reproductive, maternal, newborn, child, and adolescent health and nutrition, it really depends not only on health sector interventions and sustaining those interventions, but also on other wraparound interventions in social protection and otherwise. So thanks for making that point. Let's now go to Dr. Famafi. You have worked, you used to lead the World Bank anchor, so you know the bank as well. And Dr. London mentioned the importance of health systems. Of course, there's billions and billions of dollars from the World Bank that are tagged for this use. So I wonder if you could reflect, of course, on malaria, but also on sort of the broader international response in the preservation of essential health services.
Thank you so much. I think one thing that we tend to underestimate in terms of progress in health system strengthening is that there has been a very quiet revolution that has been growing towards migrating to digital technology for maintenance of routine health information systems, and that has been fortified by the participation of the not-for-profit private sector, particularly the health institutions, which have been strengthening assessments, data quality assurance, and increase the training and development of qualified workforce in this area. And indeed, this quiet revolution has seen increase publicly available data. That is why more data is available now to track this pandemic than previous ones. Independent institutions like Johns Hopkins, for example, are able to synthesize publicly available data into COVID-19 data dashboards, reflecting domestic global trends, incidents, recoveries, and deaths. This was not possible just a few years ago. This is progress, but what is debilitating about this pandemic? It is even that recent progress that is driven by the digital revolution. It's also dissipating. That is what is crashing about this pandemic. So, given what other members of the panel has been saying, the implications here is that we have to think of a new normal. We have to rebuild a new normal in health system strengthening and delivery. We cannot continue with what we were doing before. And we have seen a revolution. For example, many countries in Africa are using data to inform management policy decisions, whether it's malaria, HIV/AIDS, maternal, newborn health, and child health, etc. But the revolution was not fast enough to be able to have systems that were strong enough in order to be able to withstand, the winds that have battered it with COVID-19 pandemic. So, what do we need to do? I believe that we have to really focus on strengthening health systems as strengthening the social determinants. Somebody talked about this before, but I think we have to accelerate this revolution to ensure that we not only deal with the public sector, with public health sector and private health sector, but also with primary education, secondary education, tertiary education, and care-oriented health services at community level, redistributive universal rights-based and life cost-based social protection that is really focused and targeted properly, and people essentially, whether they should, a people-based approach, essentially whether it is early childhood, in youth, or as women or the elderly, should be the drivers of change. I think this is what this epidemic is teaching us and what we need to learn. So we need to restructure a new development paradigm that has been defined by the lessons that we have learned from this pandemic. If we do not do that, I do not feel that given our pace and the capacities that we currently have, whether it is domestic or international, we will not be able to survive the next pandemic. So I believe we have an opportunity here, but it will need a huge lift in terms of international development cooperation for us to take us to where we need to go. Thank you.
Thank you, Joy. And when you think about that future international cooperation that you've just mentioned in support of a new paradigm, how does that look different from what we do today? What kinds of changes would you like to see?
Well, first of all, I think we have to democratize health. And by democratizing health, I mean we have to appreciate that health starts, at community level. So the strongest part of our health system should be at community level, not at a national level, but at community level, at district level, at provincial level, at state level. That is where the strongest health systems should be. And this challenge that we have been facing right now for us in developing countries is that we have been developing our health systems at the top, to the extent that even our infrastructure is more developed at the top than at the bottom. So we have excellent tertiary healthcare facilities, but sometimes which are under-resourced in terms of equipment and qualified personnel. But the basic primary healthcare system at community level is weak. So this is how we need to now restructure our investments. Make sure that we have quality education. Africa has got a huge number of nurses that have been trained and that are out there unemployed in the communities. And a lot of them cannot actually offer quality healthcare services because of the quality of training that they have had. So we need to invest in quality human capital development. So I believe this is how we need to rethink our development paradigm and focus on prioritizing what the community needs rather than prioritizing what we believe are going to be drivers of economic development and increased wealth. Because well-being is much more important than wealth. And I believe we'll be focusing more on wealth than on well-being.
Sounds smart. Let me go back to you, Helen, and come back to you, Joy, too, on the question of data and accountability. So PMNCH is, in a way, a kind of accountability framework and mechanism for the provision of these key services. How is PMNCH using data to hold policymakers accountable at the international or at the country level? What else would you like to see in this space? What else do we need to keep people's feet to the fire?
Well, certainly with the commitments that have been stumped up for the call to action, we'll be looking to see that the money's actually invested. But I think also more broadly, we have a role of highlighting the fact that we do have a Sustainable Development Goals agenda, that every country signed up to it, that it has objectives, that these need to be invested in, and not let people off the hook where these commitments affect women, children, and adolescents. I mean, I think with the response to this pandemic, there's so much learning to do, and Joy is right. We've got to go back to basics. Partly we're going to defeat this pandemic because communities got very engaged in stopping transmission. Primary care, communication with publics, good leadership, combined with following the science. This is all incredibly important. Where leaders have gone into denial, there's been disastrous pandemic experiences. So I just hope that from this catastrophe will come insights into how to organise ourselves better, and also to ensure health system continuity, because it's deplorable that a third of sexual and reproductive health services are disrupted by the pandemic. There are essential services that just must go on and haven't. And yes, PMNCH does have a function to call this out and call it for what it is.
Thanks. I mean, I do want to draw attention. For example, the UK announced its plans to cut aid. And if you look at their aid budgets, after they honor their already announced multilateral commitments, that means that their bilateral aid would be cut by about 60%. So it's a very significant piece, and a lot of UK bilateral aid really is financing country-level RMNCH. I presume that we'll be looking for multilateral mechanisms like the World Bank and others to assure a counter-cyclical spend, if possible, with partner countries. But that also means IDA, the concessional financing at the World Bank, needs to be augmented as well. And there's an ask on the table that so far is under discussion. In addition to all the other things we've talked about, Act A, COVAX, there are a lot of asks right now. So, Ole, do you think about how is it that we on the outside in universities or civil society, think tanks, accountability mechanisms, what is it? How should we be framing this discussion? There is this reality that there are constrained resources. We want to do as much as possible to at least maintain the status quo, but that is not what's happening. So what kinds of arguments can we marshal? How do we think about this?
Yeah, so it's deeply problematic with the cuts in aid. But I think the SDGs has pushed the responsibility to countries. And I want to echo what Leslie said about the determinants of health. Poverty is driving health inequality. And I think country needs to think about tax for development and for UHC and for UHC reform. Countries need to develop universal health care with fair financing so that resources are redistributed from the better off to the worse off and from the healthy to the sick. And to build universal health care within their own country with support from all of the population and serving the whole population. And to do that, they of course need technical assistance, they might need financial assistance, but a lot of countries are now embracing UHC reform. And a lot of countries are learning from other middle-income countries like Thailand and other countries who have achieved this. So I think the responsibility is now on national governments. I think we need to face those facts, although it's deeply problematic that AIDS is being cut down.
Leslie, you're, obviously South Africa aid is not very important as a share of total spending that happens. But on the other hand, the South African economy has been affected pretty dramatically. How do you see the government grappling with some of these choices? You've talked about a holistic view. What do you hope to see next to preserve essential services at this time? Like, what would you look for from the university standpoint?
So I should just to clarify, so I'm speaking here both as a university academic and as a member of the People's Health Movement, which is a global social movement committed to the right to health. And I think the COVID epidemic arrived in South Africa at a point where South Africa was talking about universal access, was talking about a national health insurance, was talking about equity and access to all the things we need to be healthy, plus healthcare. That has sort of taken a back burner, but this is the ideal opportunity for us to restructure the health system in order to make that a reality. So if every South African is going to need a vaccination card, that card can be the NHI card for the universal health access that's coming. And that's what we hope, that government, that our health managers, leaders will grasp the opportunity to make sure that, what happens in the post-COVID era is not a replication of the same dual tiered system of inequality, but actually builds up something which is real, which makes access for everybody a reality in terms of our constitution, which South Africa has amongst the most progressive in the world.
Yeah, in a way, crisis is also an opportunity, right, to change the way things are done traditionally and to take hard decisions on reform. I just want to go back to the data issue that Joy raised. It's true that this is, especially thinking about vaccinating such a large share of the population and an adult population, could be an opportunity to deliver other services as well. How are the countries that you work with thinking about this issue, or what are your thoughts?
Well,
So,
I'll just...
sorry.
Sorry.
No. Go ahead.
I beg your pardon. I thought the question, whom were you asking?
I was asking you sort of,
Okay.
Leslie talked to us about crisis also being an opportunity for reform and moving forward on the universal health coverage and national health insurance scheme that had been under discussion in South Africa for some time. I was sort of asking you about data, how you might use, you talked about the blossoming of digital data, new ways of doing it, as we think about vaccinating an adult population, that seems like a great opportunity to talk about new ways of providing care, building that community level effort. What are your thoughts on that? Is that also an opportunity to leapfrog the health system to deliver vaccination in real time and using digital and things like that?
Absolutely. In fact, in other areas, including in health, throughout Africa, there has been, as I said, a digital revolution that is ongoing, but that has been, very, very slow. And I feel this is an opportunity for us to accelerate it. Someone talked earlier on about the fact that the SDGs have actually pushed the responsibilities for funding to countries. In Africa, we actually have been engaged in trying to get the private sector to be more aggressively involved in development. And this is one area, the digital space, where the private sector has got a lot of capacity. And as we all know globally, it is the one industry that has made massive profits during this pandemic, unlike other industries that has collapsed. So I think there's an opportunity here for this industry to actually drive this revolution and make sure that, as you say, we get information, education, contact with everybody who needs to be vaccinated, because the access, particularly to mobile technology, is extremely wide in Africa. But I think one other thing that we have to appreciate is that, yes, the epidemic has caused severe disruptions in health service delivery and in access. But it is not just because of the severe stresses on the health system's capacity. It is due also to the multidimensional poverty that has now struck many households and communities. And this multidimensional poverty has to be addressed effectively. And we have learned a lot of lessons in the past about how to properly structure social protection so that it can actually lead to economic development, growth, and increased investment in economic activity. So these are the lessons that we have to take into this. And the digital technologies are very, very well adapted to this area. So I think it's a combination of approaches that is going to get us over this hurdle.
Okay, thank you so much, Dr. Joy. So I guess that our time has run out, so we'll conclude this panel, but I think that was a good place to stop. We're talking about essential services, not just as health interventions, but also as social protection interventions during this time, the critical role of data and digital in the real-time monitoring of what's happening. And I think, when I showed that great slide from Pakistan, the great part is that we're having this information in real time. And in place in an area like malaria, for example, where you, Joy, have worked for so long, the ability of a rapid diagnostic test to tell us whether it's malaria or something else, and to know that in real time, to know where cases are happening, that has transformed the care and attention to malaria in a lot of countries in sub-Saharan Africa. So I think we can, I also think what we've emphasized here is the ability of health systems to bounce back is absolutely vital. This has been a big hit, but we do see some optimistic signs. We will have to watch the funding landscape, both in terms of government spend and aid spend as we go forward. But thank you to all the panelists for your contributions. And I'll turn it back over to our Master of Ceremonies. Thanks so much, everyone.
Thank you so much, Amanda Glassman, for such